everyone, and welcome to the Byolete podcast, the podcast where we discuss the science behind the brand. In this week's episode, we're going to be discussing a case study, actually, something a little bit different. So I think Lee's got one for us. You're going to say it, and then we're just going to have a general chit-chat about it and see if there's anything that people can take from it, because I think that it's going to be quite a typical presentation, potentially.
It is, yeah.
But yeah, let's get into the episode. So before we get into the episode, I just wanted to point out that there's been a bit of a development in the actual business side of things, so with the Byolete, the company, this week. So if anyone is watching on video, so on YouTube mainly, we actually got a sample of our test kit through today. So that's quite exciting. But yeah, so it means that things are moving in the correct direction, and we're hopefully not too far away from launching, which is exciting.
No, so we've got to authorise it next week and then see how long they say to print it all.
Yeah.
Hopefully not too long.
I know. Hopefully not. We've been waiting for ages, haven't we? But it'll all be worth it in the end. But yeah, I just thought we'd mention that because it was quite an exciting thing for us, wasn't it?
It is. And so this week we thought to do a case study. So I've not told you about it, apart from about 5 minutes before the podcast. Mm-hmm. And it was just to go through the importance of why blood testing should be involved in a lot of people's lifestyles now. And I want to point out that this is anonymised, the data, and it was taken from a case study from Peter Attia. So I think this was from back in 2019. So do you want me to go into it?
Yeah. Tell me.
Yeah. I didn't know whether we wanted to go into anything else before it, but yeah, so this is going to be called Patient B. So she is a 43-year-old female, European descent, and she has a BMI of 19, and she's got a low muscle mass. In terms of her medication, she's on nothing. In terms of her labs, in terms of general blood markers, they were okay. Nothing stood out really in terms of her blood, cholesterol, etc. Her family history is littered mainly with uterine cancers and lung cancers. There's no cardiovascular disease, and her brother's got Parkinson's.
Right, okay.
Imaging. There was no imaging done in terms of chest x-rays, CT scans, nothing like that. And then her exercise. So this is why I brought it up really, because this lady was doing yoga twice a week, so less than you. She was doing limited or infrequent weight or resistance training, and she done a HIIT boot camp once a week. So, I mean, for a 43-year-old person to be a 19 BMI, again, BMI is quite... It's not as accurate as we'd like it, but there's a good chance that she's got a low body fat percentage in this. Yeah. But the fact that she's active at that age is quite rare, really. Yeah,
I think if that patient come to me in the clinic, you would think, oh, you know, you're doing really well. And in fact, saying that, I did actually have a patient who was very similar. She wasn't 43, she was older than that woman. I think she was about 70, but perfect BMI. She looked very well. You know, I think she was a farmer, I think. So she was very active in terms of, you know, always doing something around the farm. Yeah. And she had type 2 diabetes. And again, it's that thing, like you say, unless that you would have checked her blood, you would never have known, because she's not the typical presentation of a type 2 diabetic patient.
Yeah. So I'm not taking anything away from this patient. She seems to be doing quite well anyway. Yeah. Her diet, so she does time-restricted feeding, which is she does an 18-hour fast to 6 hours feeding, so that's quite a lot. Yeah. I looked into, a side note, I did look into time-restricted feeding the other day, fasting, and it was something that we were doing at one point, but there was quite a lot of muscle lost during the fasting period, which I didn't really think of, and we were talking about the balance between building muscle, losing muscle and fat, but that's what she's doing. And her diet is composed of 55% fats, 18% carbohydrates, and 27% protein.
Okay.
So it's classed as low carb, high fat, and saturated fatty acids mainly come from dairy and meat.
Okay.
Okay. Now, the reason why this patient was seen in the first place was, I think, it doesn't really say in here, but when he sees a lot of patients over there, he does like this generic metabolic profile for a lot of patients. So, like you said before, there's nothing inherently bad about this patient. Yeah. So she wouldn't need to go to A&E, a GP, but he just does this for, what would you call it? increased detail about insights into her health?
Yeah, basically what we're trying to do with Byolete, to be honest.
Yeah.
It's just giving a patient an understanding of where they're at, metabolic-wise.
Yeah. So the main test that we're going to talk about today is the oral glucose tolerance test. I'll go through what that means.
I was going to say, I'm not very familiar with it because it's not a test that I've ever done. It's not a test that we do on the NHS. So I wanted you to just explain it a little bit more. I do have a vague understanding of it, but...
Yeah, so the oral glucose tolerance test, we normally do it for people we suspect diabetes in. And like we've said before, I've had this test when I was 9. And in the UK, we do it where you have 75 grams of a sugary drink. So the process is you have a fasted period of 8 to 12 hours.
Yeah.
You go into the clinic, you get a blood test. So that's your fasting blood glucose.
Yeah.
Ideally, you get your insulin.
Well, I was going to say, so this is the part that I'm saying, when the NHS don't do it, I have never seen an insulin level done.
I've never seen an insulin level or a C-peptide.
Okay.
Yeah, I've never seen any of them
so
done.
That's why when I said we didn't do it on the NHS, we do a glucose tolerance test, but we don't measure insulin, so it's not the same one as what we're going to discuss.
Or if we do, it's never reported on our system that I've ever seen anyway.
Yeah.
But yeah, so you go in a fasted state, you have this 75-gram sugary drink, which is horrible. And the idea is that you test your blood sugar, insulin, C-peptide at frequent intervals.
Yeah.
And then
C-peptide, by the way, is... It's a peptide that's released at the same time as insulin, but it's around for longer than insulin is. So insulin has got a half-life, which means that it's destroyed within a couple of minutes, isn't it?
Yeah, 3 to 6 minutes.
Whereas C-peptide is around a lot longer. So usually we would test that because it's more stable to be able to test.
Yeah, so insulin, when we secrete it, it's inactive. And like you said, there's insulin, which is the active form, and C-peptide. So it makes one big pre-pro insulin.
Yeah.
And then we cleave it to insulin and then C-peptide. But like you said, C-peptide stays around for longer, which means that if we suspect someone is not making enough insulin, they will have low levels of C-peptide. If they've got high insulin levels, it's normally come from an exogenous route. So it's being administered via a device. So you go into a fasted state, get your test done, you have the sugary drink and you test it at certain intervals. And the idea is to see how your body responds to glucose within the system. How does your insulin react? And we do it for over 2 hours, basically. And then we assess whether you've got any form of diabetes from it. Now, this lady who come in, again, we need to convert it across the 2 units because the Americans use milligrams per deciliter. We use millimoles per litre. So this lady's fasting blood glucose was 97 milligrams per deciliter, which equates to about 5.4 millimoles per litre.
Okay.
Now, for anyone who wants to know reference ranges, in the UK, we look for 4 to 5.4 or 5.6, give or take, as a fasting blood glucose. Anything above that, up to 7, is impaired, and above 7 is diabetic.
Yeah.
So this lady's was fine. She was classed as non-diabetic. Her insulin level, now this is quite hard to find because there's no real reference ranges within the UK. But this lady's fasting insulin level was 6.
Okay.
Now, from the studies I've read, below 10.
Okay.
Ideally below 6 or below. So she is where we want her to be. So from a metric point of view, she looks healthy.
Yeah.
So they've done this oral glucose tolerance test. Now, her bloods were measured at baseline 1 hour and 2 hours.
Yeah.
After an hour, her glucose was 227 milligrams per deciliter. So it shot right up. What is it? 2.3 times shot up. Her insulin went from 6 to 86.
Oh, wow.
Yeah.
Okay.
So I'll come back to this, why it's significant later, because at the end of the 2-hour fasting, phase, the testing phase, her blood glucose went down to 129, which...
It's still high.
It's still high, but we have less than 140.
Oh, okay. It's considered
a normal response.
Okay.
So in the UK, less than 7.8 millimoles per litre after 2 hours is good. Peter Attia goes for a lower level. He wants it to be 100 and less.
Okay.
But either way, this lab's authorised as okay.
Okay.
Insulin level, by the way, is still raised at 52.
Okay.
Now, for context, the insulin level should go down to twice the baseline. So in this patient, she had a baseline of 6. It should have went back to around 12.
Right, okay.
Now, if you just took this patient fasting levels, she's healthy.
Yeah.
You've just done this test and we've just noticed that her body's struggling to utilise sugar in the system because her insulin's gone disproportionately raised and her blood glucose spiked at 227.
Right.
So this is why I thought I'd bring it up, because we test a lot of patients' blood in a static phase.
Yeah.
That's one snapshot into all the minutes in a day.
Mm-hmm.
Whereas you've just seen a simple 2-hour test here has given her a completely different dynamic picture.
Yeah.
So I think you've had a bit of a look, but what do you think's the issue at the moment, or what could that lead to?
So it sounds like there's also a score that you can do, which is called the HOMA IR score. I had a quick look at it because I've seen it a couple of times this week as when we've been looking at things. Again, it's not something that we use in the NHS. I've never seen it being done anyway. But it gives you a marker, I think, of insulin resistance. Anything above 3, I think, indicates that there is insulin resistance. Is that what you
I don't know. I didn't look into that.
Yeah.
But I know there's the HOMA IR and then there's one called QUIC.
Okay.
Which is insulin sensitivity, but yeah.
Okay, so yeah, they're the markers of basically how well someone is being able to use insulin and glucose as an energy source. So I would say that she's probably got, well, she has got insulin resistance.
She's got some degree of it,
Some degree of it. I would say that it's one of the things potentially could be that she's got a low muscle mass. So we know that muscles are the biggest reservoir for the storage of glycogen. And also if you have a greater muscle mass, then it doesn't necessarily need insulin in order to be able to store it. And so basically if she hasn't got enough storage of being able to store glycogen, then glucose is going to stay around in the system for longer.
Yeah, so that's the first sign of insulin resistance, is that your muscles are basically experiencing it. Yeah. Liver and pancreas are more secondary to muscle, but yeah, if you have a higher muscle mass, it's a bigger reservoir. I think, top of my head, 80 to 90% of sugar that's absorbed within the diet gets stored as glycogen within the muscle and liver.
Yeah.
So if you're impairing that, because insulin resistance is first due to a lack of ability to store it as glycogen, isn't it, due to fats within the muscle cell?
Yeah.
So if you've got that lack of ability, it then will go from insulin resistance mildly up to full-blown diabetes, type 2 diabetes.
Yeah.
But in this case, the advice given was, before we diagnose anything, to give a continuous glucose monitor.
Yes,
I want to do that because HbA1c, which we've said before, which is on the panel that we're doing, is a good, how would you put, indicator?
Yeah, I think it's a good starting point. And that's why we use it on the NHS, because it's very easy to do. It's very simple to interpret, and it does give you a good idea.
Yeah.
Obviously, an oral glucose tolerance test when you're testing glucose and insulin levels would be the gold standard, but you obviously don't have to sit a patient there for 2 hours. It's invasive because you're going to be taking bloods at different times, so it's multiple times that you're taking blood, and it's probably expensive because there's more resources that are needed to be able to do that. Then you're going to have to train people on how to interpret the test because we don't get taught it. So yeah,
there's a lot to it. And
there is.
When I looked into it more, there was things that affected an oral glucose tolerance test that I would never have thought of, or I thought of it in the incorrect way. So if someone's on a ketogenic diet or haven't had carbohydrates for, let's say, a week before, you're meant to refeed them 3 days before.
Yeah, you mentioned this to me.
Pardon me. But the reason I thought was completely the opposite. So I thought if you had a lack of carbohydrates within the body,
you'd be more sensitive to
it, so you take it all in. But actually you exhibit physiological insulin resistance at the muscle, because the idea is, or the theory behind it was, that if you've got a low blood or a low sugar intake, you shunt that blood glucose to the brain.
Okay.
So you don't want it within the periphery.
Okay.
Again,
it's
so that's the downside of that test. There's it's invasive, it's time consuming, there's a lot of things that we need to do, train personnel up. HbA1c is a good indicator.
Yep.
There are obviously downsides to that in terms of if you've got abnormal cell division,
red blood cells,
excretion, etc. It changes the results. But in this case, if you can get a continuous blood glucose monitor, that's like...
Which anyone can buy, by the way. You can buy it online. I think they're pretty expensive. I haven't checked for a while, but yeah, anyone can buy them. We actually did have someone who came to it, or who messaged us on Instagram, didn't we? Who she had pre-diabetes, and we recommended to get the continuous glucose monitor because it gives you just a better idea of actually what's going on. And also, we know that people respond differently to different foods, so it's so individual, and we're obviously just starting to recognize that with the likes of Zoe and people who are doing it, where I could eat an apple and have one response with my insulin, whereas you could eat the same amount and have a completely different response, and the continuous glucose monitor will pick that up.
Yeah. So going back to this lady, so her average blood glucose on the monitor for 8 days was above the target. So it was 112 milligrams per deciliter. So it was above the 5.6 millimoles per litre that we would like in the UK at any time. So it did show that for some reason, whether it was a lack of muscle mass, insulin resistance, whatever it may be, that she was unable to utilize sugar and store it effectively.
Yeah.
So in her case, like you just said then, there's no one size fits all. You might be able to pile away 500 grams of carbohydrates. This lady here clearly can't put too much away.
Yeah.
So her diet would need to be optimized towards her. Otherwise, she's going to keep spiking insulin, using the wrong fuels, having fat deposits, etc. It could cause a cascade of metabolic dysfunction, or because she's not eating towards her body's optimum environment. I just thought, I thought that was
I was also going to point out that I'll have to look into the actual physiology of it and why this is affected by it. But obviously, 43-year-old, she could be perimenopausal. We know that as estrogen levels drop, that does decrease insulin sensitivity. So you're more likely to get insulin resistance as you do hit the menopause, whether it's to do with visceral adiposity. So, you know that women who are in the menopause tend to store fat around the abdomen, which is considered the worst type of fat to store.
Yeah.
So that could have an impact on, or could have. So there's a lot of things that you could optimize with that woman, is the point.
It is. But if you actually look back to her presenting condition, by the way, she didn't present, but her initial review, 43, female, BMI of 19, so the reference range is she's
18.5 to 24.5.
Yeah, in white people, white Europeans.
So she's actually she's obviously within the healthy range, but on the cusp, really.
Exactly. She's active. She's not inactive. Her diet seems well controlled. So looking at her in the street, you wouldn't think of anything.
Yeah.
And even looking at her bloods in a fasted state in one snapshot, you wouldn't think anything. But it was only until we went into the metabolic profile that actually, oh, something's going on here. If that was to be left untreated for 10 years, 15 years, she could go from full-blown, well, mild insulin resistance to full-blown type 2 diabetes, which is the whole point of why we're trying to get people to at least test once or a couple of times within their lifestyle. Well,
and why we're telling people as well, so that woman's 43, really we're saying anyone really above the age of 25 should at least do it, like say once, and then as you get into your late 30s, I would be doing it potentially every year, at least. So it's just so that you have a greater understanding and you can actually do something actively about it, because you've probably got a good analogy about this.
In terms of which?
In terms of what you wouldn't do. You wouldn't buy a car without literally looking at all of the spec on it, or
I get what you mean. I mean, you survey a house, don't you? You don't just look at a house by its facade. You look at what's inside, the foundations.
Yeah. So you wouldn't do that with anything else in life. So why would you do it with the number one asset and the most precious asset?
Because the body is so able and capable of dealing with all these situations that you won't even know about. Your body's dealing with insulin resistance for 10 years on average before you show type 2 diabetes. 10 years where you don't have a clue. And that's the thing that I wanted to touch upon, is that when you measure, this plant keeps getting in my face, but if you were to measure glucose, it would stay normal for a while, which hers is.
Yeah.
And then only after a point will her insulin start rising disproportionately, but still keeping her glucose normal. And then the only sign that we pick up is when her glucose goes higher. That's the first sign we intervene. But by that point, her insulin could be 3 times what it should be.
Yeah.
And we've intervened quite late. And then it gets to a point where the liver becomes dysfunctional and then just doesn't listen to insulin. And then you get increased glucose production, and then it just goes into a full metabolic storm from there. But I just thought it was interesting because we always talk about your training regime.
Yeah. I think
you do Pilates as well as yoga. You do yoga every day, which I think you need to do. You need to do mobility. Yeah. You need to do the breathing techniques. It is hard. I find it difficult.
I think, to be honest, I haven't been doing it every day recently. I think I have slacked a little bit, to be honest, with my training over the last couple of weeks. I've been trying to incorporate more conditioning. So I've been doing a couple of classes, and I'll do the spin. But yeah, I think with yoga, I do enjoy it because, like you say, it's more for my mind as well as like physical, but I think I need to do more strength training because, you know, building muscle mass is great for insulin sensitivity, but also just for longevity in general, and especially as a woman. And, you know, I'm only in my early 30s, but especially as I get to my late 30s, early 40s, I need to make sure that I'm maintaining that muscle mass, because as soon as my estrogen levels drop, you know, my bone mineral density is going to drop, and I need the muscle to be able to support my skeleton, so that, you know, I'm at less risk of fractures and things. So it is, I mean, it's important for everyone, but especially for women, especially at my age, I would say.
It is. And the one thing, the more we look into insulin resistance, muscle density, all these things, I find it hard to find where the balance is. So with my condition at the moment, I obviously want to increase muscle mass because that's my friend. It's going to use glucose as a reservoir and store it. But then if I go into an anabolic state, I'm secreting insulin at higher levels. So then what I need to do really is go into a fasted state a few more times, go into autophagy, let the body recycle certain things, let the body have a break from insulin and glucose. But then if I do, the studies are showing that your lean mass drops so much.
But is that even in people who train like you would train?
I mean, the two stimuli to muscle synthesis are strength training and protein intake. So if you reduce protein intake and you still train heavy, you will still get some form of stimulus, but not to the extent that would preserve the muscle in great enough quantity. Because if people ever go into like a calorie deficit, for example, they'll have high protein intake to try and prevent degradation. But that's one thing I'm going to look into more, is where is the balance between an anabolic state, a fasted state, with regards to keeping your metabolic function intact.
But you know what the good thing is that you're actually aware of it and you're doing it, and now we've got the testing kits where we can actually check it. You probably will get a continuous glucose monitor. So I think that's what life is about, really. It's just being aware of something and obviously not letting it completely consume your life where you won't do anything, but just being aware of it so that, you know, you're not being naive to certain things. And yeah, just trial and error, isn't it?
It is. Now, that was one case study I picked up.
Yeah, I enjoyed that. I'm
sure you're going to do and find one, not tell me what it is, but it's going to be around the idea of cardiovascular metabolic disease, because we don't want to throw each other off. But I think it'd be a good idea if you pick the next one.
Yeah, I think as well, I wanted to just sort of put it out there if anyone is actually getting to the end of this podcast and listening to it, but we actually wanted to maybe bring in a few people who want to tell their own stories about, you know, experiences that they've been through with the health, mainly at the moment specifically to do with cardiovascular and metabolic disease. So let us know if that's something that you would be interested in us doing, because it's something that we've been thinking about for a while. And I'd just be interested to know if people would resonate with that more, you know, with having people come on to tell their story.
And deciphering someone else's story.
Yeah. Because I think that sometimes when, you know, you said it with a case study, and you get this when you training, you know, in university and stuff, it's not a real life person, so you can't really relate to it. Whereas if there's a physical real person there telling their story, you're more likely to take on the information and think, oh yeah, because I think a lot of the time you think, oh, it wouldn't happen to me, you know, unless you then see it and you go, oh, you know, it hits home a little bit more.
That's why I thought I'd bring that one in, because that was actually a real patient who you wouldn't suspect anything wrong.
No, I think it was really interesting, but I'm just saying, you know, in the future we should maybe, we wanted to do that, and
we'd have to go into a studio as well, wouldn't we?
Yeah.
But yeah, I enjoyed that. I'll let you pick the next one.
Okay. Well, yeah, so if you got to this point, thank you so much for listening. Please subscribe and like this video if you haven't already. Again, you know, follow us on Spotify, on Apple Music, on whatever platform you are listening to us on. But thank you for listening, and we'll catch you at the next one.